joining us this morning for today's press conference with UNM Health, Presbyterian, and Loveless on COVID-19. Just a reminder, this will be recorded. If you do need a copy of it, please let me know and we will get that to you once we are completed. And just a reminder to everybody to please be on mute with the exception of the speaker. So each of our experts will give a brief statement and then we will open it up for questions. I will go ahead and turn this over to Presbyterian Chief Safety Officer and Medical Director of Infection Control, Dr. Jeff Selvin-Harmon. Go ahead, Dr. Selvin-Harmon.
Good morning, thank you. So I want to take a moment to speak about our hospital volumes and the amount of community transmission that's occurring and impact on our hospitals. Over the last 4 weeks, we have seen just tremendous and unprecedented increases in community transmission that has resulted in never before seen volumes with COVID-19 infections in our hospitals. This is having impact on our resources, our staffing, and pushing us to near to the point of what we would call a crisis. And this is something that everybody in the community has an opportunity to impact. It's the adherence to our COVID safe practices. It's the adherence to our current public health orders that can slow the spread of this virus infection to the point that our health systems will be able to
Sorry to cut you off, Dr. Selvin-Harmon. We're having some issues with your microphone.
Okay.
So yeah, we'll go ahead and I'll send it over to Dr. Vesta Sandoval, and then we'll circle back to you, Dr. Selvin-Harmon. So I will go ahead and introduce Loveless Chief Medical Officer, Dr. Vesta Sandoval. Go ahead, Dr. Sandoval. And Dr. Sandoval, you are on mute.
All these technical difficulties. Can you hear me now?
Yes, go ahead.
Okay, great. Thank you for allowing us to come and speak in front of you again today. I just want to say that, having been born and raised in New Mexico, practiced my whole career here, I know how important family and community are to New Mexicans. We need to pull together in this time, and we need to really focus on taking care of each other. And the best way that we can do that right now is not to gather, to stay home, and try and really focus in on the fact that this is what we can do to control this virus. I've seen entire families impacted by this virus. Husbands and wives in the ICU together, brothers and sisters, grandparents, parents, children. So right now, one of the main ways the virus has been spread is by family gatherings. I really want everyone to focus on the fact that we're here to help each other. Our healthcare providers are doing everything that they can. Our facilities are doing everything that we can. But if the virus continues to spread as it is, we are not going to be able to take care of the numbers that we're expecting. So we really need everyone's help. We need New Mexico to pull together, pitch in, and really buckle down during this tough time and do all the things that we know we can do to prevent the spread. So thank you.
Thank you, Dr. Sandoval. We'll go back to Dr. Selvin-Harmon now.
Thank you. So building on what Dr. Sandoval was saying, and very much in alignment across our systems, this is a community crisis. Cool. This is an opportunity for all of us to demonstrate our humanity by taking care of each other. The things that we do for COVID-19 are not so much purely protective of ourselves.
Hi, Dr. Selvin-Harmon. Sorry again. Your mic is still a little bit muffled and we can barely hear you.
Dr. Selvin-Harmon, can you get any closer to the microphone? Maybe I know that's a little awkward, but.
I can try. Is that better?
That's better, yeah.
Everyone else, can everyone else hear? Okay, great. Go ahead, Dr. Selvin-Harmon.
Okay. So what I was saying is that this is really a test of our humanity, because the things that we do to prevent the spread of COVID benefit us ourselves in the minority, but the majority of that benefit is to benefit others around us. Wearing the mask is to protect others around us. Keeping our hands clean both helps us and helps us to not transmit to others. Physical distancing helps to prevent transmission, not only receiving it, but giving it. And so I really issue this plea to our communities to find your humanity for the next few weeks. Bring this under control. It's a very difficult time with the holidays approaching, wanting to be with families. But if you think in the long run that those things you do now and the get-togethers you may forego this year because of the pandemic will help to ensure that those family members and those friends are there in the next years to enjoy those get-togethers. Whereas if there is spread in family gatherings this year, it may cost lives, and it may mean that some of those individuals are not with us next year and the years thereafter to enjoy those holidays. So I ask you all, please, to find your humanity, to think of yourself as well as those around you, to not make assumptions about who is free of the virus and who is not, and to protect yourselves and to protect your family and your community while we come out of this surge. Thank you.
Thank you, Dr. Sullivan-Harmon. Next, we'll go to UNM Hospital Chief Quality and Safety Officer, Dr. Rohini McKee.
Good morning. Can you all hear me okay?
Yep, you're good.
Great, thank you. Thank you for the opportunity to talk to you today. I'll try not to be redundant here, but as we head into this holiday season, I'm going to ask all New Mexicans to consider two things. Firstly, I know we are months into this pandemic and pandemic fatigue has set in. But to get control over this virus in the few months before we get the vaccines, we really need to be patient and selfless and draw on our reserves of fortitude and consideration for the most vulnerable amongst us. And no matter what you celebrate over the holidays, they are a time that we normally, even outside of COVID, stop to think about those who are less fortunate than us and those who are the most vulnerable in our communities. And I think that this year we are just called upon to do that a little bit differently. The second point I'd like to make is that as we saw with the first surge, the virus doesn't just cause direct harm, but it also affects the health of our communities by preventing people who really need medical care for other reasons from getting that care. And so we are asking everyone to do their part. Avoid gathering in large groups, follow COVID-safe practices, get your flu shot, because this will create capacity in a medical system to care for all those patients who don't have COVID but still need a hospital bed. And if you are feeling ill, please seek medical care. Your doctor's offices are open for in-person visits and many are offering televisits, so please take advantage of that and do not postpone necessary care. So thank you again for the opportunity to talk to you today, and I look forward to taking your questions.
Thank you, Dr. McKee. We will go ahead and open it up for questions. If you have a question, please let me know in the chat and I will call on you. We will start with Brittany Hope from KOAT.
Hi, everyone. Doctors, thank you so much. We really appreciate it. A few questions kind of about the Thanksgiving holiday, and it's three-pronged. So first of all, we know there's that incubation period that everyone is worried about, and we know that can take up to a few days to a few weeks. How long do you think it will take for us to see the impacts of this Thanksgiving holiday? As much as we warn people and ask people to not gather in groups, we're seeing the lines at grocery stores and we're seeing it start to happen. So how long do we think we'll see that reflected in our hospitalizations? On the same token, when do we expect to see, hopefully, the helpful effects of this new public health order? Today begins week 2. When do we think we should hopefully see that? And then third question, talking a little bit about the Gibson Medical Center, I know people have to be referred there and that comes from their practitioner at the hospital. Have you sent anyone there yet? And when do you plan to do so, if not? And that's it for me. Thank you all again. We really appreciate it.
So what we know from this virus is that from the time you get infected to the time that you show symptoms and then require a hospital bed and then potentially a ventilator, that time span is about 3 to 4 weeks. So if we don't see the behaviors that we're hoping for from the community, we are going to see that reflected in our inability to provide care because we are full in about 3 to 4 weeks' time. The public health order question, I think, is a little more difficult to answer. And that is because we know that, as Dr. Sandoval mentioned, a lot of our spread is coming from family gatherings. And so stopping that spread is dependent on people understanding how risky those behaviors are and changing their plans for the holidays. And so if we don't see an effect from the public health order, it's going to be very difficult to tease out whether that was the public health order itself and what was in it versus the behaviors of the community around the holiday week.
And I would just add, as far as Gibson, we are aware that it's open and they are accepting patients. We are trying to actively move patients there. We're grateful to have a facility that's up and running that can handle some additional patients to help offload the hospitals. And so that will be an ongoing evolution of the numbers of patients they can take and the types of patients they can take.
I'd like to add one ray of hope, and that is regarding the governor's new public health orders. In our Presbyterian data, we keep track of the rate of positive tests every day that we run in our hospitals and at our drive-through testing site. And we calculate what's called a 5-day rolling average. So it smooths out those ups and downs from one day to the next. And what we've seen over the past week is that 5-day average is beginning to decrease. And it's not to low levels, but it is turned downward, which I attribute at this point to those public health order improvements. And it's likely a very early sign that we're starting to see the benefit a week into those public health orders. And if we continue on that trend, we will see that rate of positivity coming down, which will mean there's a slowing of spread of the infection in our community.
And a follow-up for all the doctors as well. I know we had Lovelace mention that it's kind of ongoing on the UNM and Presbyterian front as well. Are you able to say how many folks all three of you have sent so far to Gibson? Or is that something that's still being kind of figured out in the meantime?
So my understanding there is that the Gibson Medical Center is for lower acuity patients. And I don't have numbers on how many patients we've sent there or whether we've sent any patients there or not, but it is for lower acuity patients who don't require the level of care that they would get at our in one of our hospital beds.
And I too don't have ready access to those numbers, but we'll be happy to look into it and get back to you.
Thank you all so much.
Thanks, Brittany. Next, we'll go to Tessa Mentes at KOB.
Hi, everybody. Just to go off of what Brittany said, thank you all for giving these updates, and just thank you all for everything you're doing to keep as many New Mexicans safe as you possibly can. You don't get it enough, but it is greatly appreciated. I have questions about two different topics, so if I have to do a follow-up, that is absolutely fine. First, I want to really hone in on the ICU bed capacity at our 7 hub hospitals, because if you look at the Department of Health modeling site, there are 3 levels: baseline, contingency, and crisis. I would like you all to talk about where we are at this point. As of yesterday, the state showed that 294 adult ICU beds were occupied. So that puts us technically over baseline. My question though is, if we move into contingency and then God forbid crisis mode for those adult ICU beds, where do those beds come from? In other words, what services are having to be redirected to provide for that level of care? And also, when it comes to ventilators, is there a way to put a numeric significance on how many we have available, if we have enough available at this point? So there's my first topic of questions. Secondly, we always talk about bed and resource capacity. Our best resource, though, as we know, is our healthcare workers. We've heard reports nationally of those workers having to still care for people, and they've been diagnosed with COVID themselves. I know that traveling nurses and healthcare workers are coming into New Mexico, but at this point, how are we helping our healthcare workers care for patients, but at the same time balancing the need for their service with the need to keep them as safe and healthy, not only physically, but mentally and emotionally as well? I know that's a lot, so again, I'm more than happy to do a follow-up and remind you all as you answer as much as you can. Thank you.
So with regard to your first question, we have a pandemic influenza plan that we follow that allows for adjustment of resources, including our beds. But it is true that we are running out of beds. And the best way to prevent that from happening and the best way to create capacity is for the community to follow what we are asking them to do, which is to avoid gathering and to follow COVID safe practices. We have a lot of traveling nurses. Our chief nursing officer had a lot of foresight when working with the agency to bring in these nurses. And so we have a lot of help for our already hardworking staff. And we have numerous peer support programs in place and have for months to support our nurses and our physicians. It is, I think what you're alluding to is the fact that with the recent numbers that we've seen, that it is entirely possible in a few weeks that we do run out of ICU beds, which is why it is critically important that we do everything we can to stop the spread of this virus over the holiday season.
And I would just reiterate that we are in contingency. I mean, I think I heard that there was some question there about where we are sitting right now. We are in contingency. People have gone very far into their surge plans. All facilities had very well laid out surge plans about how we could expand capacity. And we're all doing that. We are close to that line of crisis. And so again, that's why this is so incredibly important that we get the message out and really have people understand that if we are put into that position, then it is going to be exceptionally challenging for our state and for all of our patients.
And I'll add to that that we confirming that yes, at Presbyterian we're also in contingency mode. We have well-described surge plans that take us much further than where we currently are at. So we are prepared for that, but it does require some innovative approaches to providing care, particularly to intensive care level patients, whether it be doubling up in the intensive care unit itself, or whether it's establishing de facto care units in spaces that can support care of those patients. In perioperative spaces or in other operative spaces like a GI laboratory where endoscopies are performed. Those are some of the overflow locations that can be used and are typically part of most plans. We absolutely are challenged right now with the staffing as much as the physical space. In fact, the physical space is slightly easier right now. And I don't want folks to be misled that the mention of traveling nurses means that they are bringing infection, because we have not seen that. In our experience, we have seen very little employee to patient or patient to employee transmission. We have seen some employee to employee transmission, but typically it's occurring in break rooms and lunch rooms where the spaces are enclosed and where folks will have their mask off while they're eating or drinking, and will be engaging in conversation. And so we're really encouraging our workforce to find innovative ways to take their breaks and spend their lunch where they're not in such close proximity when their masks are off. We're also seeing a lot of community transmission amongst our workforce that is then finding its way into our facilities. And that's because of the unusual nature of this virus, that we have so many asymptomatic individuals who can be infected, as well as those who are pre-symptomatic, those who will develop symptoms, but maybe shedding the virus for a day or two before the first begins, not realizing that they've been exposed. So it's not to say that this is intentional spread that's occurring from the community in our healthcare workers, but to say that those unintentional exposures and those asymptomatic or pre-symptomatic infections are finding their way into our facilities, and because of some of our practices are creating opportunity for transmission to occur. So again, by doing the work in the community to lessen opportunities for transmission means that our healthcare workforce will also experience less infections, will remain healthier, and be able to support care for more patients.
Thank you all so much. And actually, if it's okay with everybody, Dr. Sullivan-Harmon, I have a specific question about Presbyterian. We know that a hospital in Curry County has maxed out in hospital beds, and those patients are going to have to come to the Metro. We're hearing that they're going to have to come to Presbyterian. Can you confirm that? And if that is the case, how equipped, I know you touched on it already, but how equipped is Presbyterian and our healthcare workers? How ready are they to help with patients from our rural areas that may have to come here to the Metro to receive that care?
So Presbyterian has 9 hospitals across the state. 3 of those are here in the Albuquerque, Bernalillo, and Sandoval County area. But 6 of those are in other counties around the state. And the hospital you're referencing in Curry County is Plains Regional Medical Center, which is part of our network. And we've worked a few different strategies. For those patients who are needing low-level inpatient care, we're working in partnership with our other nearby hospital in Tucumcari, the Medical Center. And we're also working for those more acutely ill patients who would need a higher level of support to come to Albuquerque, to Press Hospital or to Rust Medical Center. We are well equipped to be able to provide care to those patients. We incorporate that into our surge planning and our surge capabilities, and are confident that we can continue to meet their needs. Our modeling predictions, however, over the next 2 to 4 weeks, with increases of continued transmission, if we don't see the benefits we're anticipating from our new public health orders, could challenge that ability, and we don't want to get to that point. So we can continue to manage effectively within our current contingency mode. We really want to do everything we can across our communities to stay out of crisis mode. And at present, we are fully capable of meeting the needs of those patients we're transferring in from our more rural locations.
Great. Thank you all so much for the insight, and stay safe out there. Thank you.
Thanks, Tessa. Next, we'll go to Algernon Damasa of the Las Cruces Sun News.
Thank you very much, doctors, for doing this. It's really helpful for us to get what information we can. I'm calling from Doña Ana County, down in the southern part of the state, which is kind of a southern hotspot. Some patients from our rural counties down here have been transported up to Albuquerque and Santa Fe. And I know that there is no representative from any of the southern hospitals in the network on with us today, but I'm wondering, are you exploring some approaches similar to a program that is being piloted down here for patients with lower levels of care who don't necessarily maybe can be treated out of a hospital setting, using telemedicine and electronic monitoring so that they can contact a provider as needed, but moving them safely into a home environment and then keeping a close check on them. I'm wondering if any of these approaches are being explored up in your area of the state as a way to reduce exposure to medical personnel, as well as to just try to relieve some of the pressure on your beds and your staff. Thanks.
You know, in conversations, I do believe that all the facilities have been looking at various levels of using video medicine, as well as trying to develop networks for these patients to be able to go home with oxygen, monitor themselves, monitor their symptoms, and also looking at ways that infusion centers can be set up to be able to use some of the medications for these patients so they don't necessarily have to be in a hospital bed. So everybody is actively working on developing these programs.
Yes, and I will second that. UNM Hospital, patients don't meet criteria to be admitted. We give them oxygen saturation monitors, check in with them frequently, and we are also setting up an outpatient infusion center for the monoclonal antibodies. And I also know that there are conversations every day of the week, including weekends, between the state and all our facilities, where not just inpatient capacity, but these kinds of initiatives are discussed as well.
And we're following a similar path at Presbyterian, exploring all opportunities to care for patients outside of the hospital setting to maximize our hospital bed capacities, looking at innovative methods with telehealth and exploring opportunities with infusion centers for both remdesivir and for the new monoclonal antibody. And excited about other opportunities with other medications that are on the near horizon, and certainly looking at the opportunities that will come with COVID-19 vaccine as vaccine becomes available.
Thanks, Algernon. Next, we will go to Francesca Washington at KRQE.
Hi, my question is specifically for UNMH, just about the press release that was sent out earlier this morning about the experimental therapy regarding the cytokine storm. I guess, can you talk more about it and kind of what this means for treating COVID patients in the future?
So Francesca, I do not have enough knowledge about that to speak to that now, but I'll be happy to get back to you on that.
Okay, thank you.
Yeah, Francesca, this is Alex. We're happy to set you up with the people who were featured in that article to discuss that specifically for you.
Great, thank you.
Thanks, Francesca. Next, we'll go to Ryan Botel at the Albuquerque Journal.
Hi, thank you, Mark, and thanks, doctors, for taking the time to talk to us. I was wondering when you talked about how the local hospitals are currently at a contingency level of care, and there's concern that in the coming weeks it could get into a crisis mode. That was my kind of understanding of what you have said. What are sort of the main data points or markers that you would look at that would indicate whether our hospitals are reaching that threshold of crisis mode? And then can you also, when you say the hospital's in a crisis mode, what would that mean to a patient? What could you kind of just describe how that would affect the care that's provided there? Thank you.
So Ryan, we look at our resources, we look at our equipment, We look at physician staffing, bed availability, nurse staffing, ancillary staff, and use those as criteria to move from contingency to crisis standards of care. And really what crisis standards of care mean is you get to a point where you focus on the good of a population, strategies that can do the most good for the most people, rather than focusing on an individual. That is sort of the definition of crisis standards of care, which is sort of one step away from where I believe all our health systems are at this point in time.
So I would add also that as the state has recently defined in a crisis standard of care, we might resort to having COVID positive healthcare staff who are asymptomatic, providing care either to COVID patients or in the worst of crises to patients who are not infected with COVID, but taking all of the appropriate preventive measures to prevent spread to those patients. That's a real challenge to our infection prevention control practices, to have somebody who has an active communicable infection providing care to vulnerable patients. That's a position we don't want to get to, but that we have provisions in place if that's the only way that we can continue to staff our facilities to provide that critical care to patients. And with those protections in place to do everything we can to prevent transmission. Additionally, crisis standards are often more informally defined by the time delay for admission to the hospitals, waiting times in the emergency department before a hospital bed is available. Looking at the ability to provide care based on the available resources. And contingencies is when those resources are being stretched and maybe intermittently or occasionally unavailable. However, crisis is when they are routinely unavailable. So potentially not having ventilators for patients who need mechanical ventilation and having to make those difficult choices about who benefits more, the person who's currently on the ventilator or the person who's waiting in line for the ventilator. Those are experiences we saw from Europe in the spring that we really want to avoid getting into, and we're not there currently. And again, the plea is for our communities through those public health orders and the adherence to them to turn this around, to flatten the curve and bring the infection rates down so that we don't get to that point.
And I would just like to add again, this is part of why we have the state health order, is to try and prevent us from going to that crisis area. And the state has helped us with guidance as far as load leveling and being able to communicate between facilities. I think we've seen just unprecedented collaboration between facilities to try and offload rural hospitals or offload each other here within Albuquerque to try and help with throughput, whether it may be, to a secondary level of care or whatever that might be. The communication is really key for us to continue to offload and prevent ourselves from ever going into that actual crisis status.
Thanks, Ryan. Next, we'll go to Nathan O'Neill at KOB, but I do not see Nathan still on here. Are you still on here, Nathan? Nope. Okay, does anybody else have a question before we bring this to a close? We'll go back to Ryan Botel at the Journal.
Hi, thanks. One more question. I don't know if you've addressed it, but I was just hoping that you doctors could talk to me about the current state of testing capacity. I know the Department of Health announced this morning that they have a new type of COVID test being offered at Balloon Fiesta Park. Just where do you think the state stands right now in availability of testing?
Well, the volumes of demand, Ryan, have been intense over the last couple of weeks. We've seen State Scientific Lab Division, we've seen our TriCore reference lab really stretched to their limits. And the result of that is that it's delaying what's called turnaround time, meaning it takes more time from the time the specimen is collected to the time it's resulted to get that the test completed and the information to the patient. And that potentially means then there's opportunity for further transmission before patients know their results. One of the strategies that we've looked at, and it aligns with the state strategy, is to employ antigen testing. So that's testing for the spike protein rather than for the genetic material. And there are antigen tests that can be run at the point of care. They're very fast, 15-minute runtime, that can give you a reliable yes answer, particularly when community prevalence is so high as it is right now. But the negatives, unfortunately, have a 1 in 4 chance of being a false negative, and so they require confirmatory testing. But if you think about all of those people who would have had a PCR test done, instead having an antigen test done, and if our community prevalence is around 20 to 25%, then 20 to 25 of those tests will result positive and not have to be PCR. So only the remaining 75% would end up being run as PCR to confirm. That's a 25% reduction in demand for testing within that group of patients. So it can be an effective strategy when the numbers are big enough. And so introducing it at DOH testing sites, introducing it at our facility testing sites is one way to reduce demand, but it is specific only to symptomatic patients in the first 7 days of onset. So it's not useful for screening of asymptomatic individuals. It's not useful for pre-surgical or pre-procedural testing in asymptomatic people. So it will reduce the demand some, but it will not reduce it absolutely across all of the systems.
Okay, thank you.
Let's go back to Brittany Hope of KOAT.
Hi again. So one of the members on our team asked us to ask you all about proning, the practice of laying a patient on their stomach, and how that may be extra helpful for folks who are critical. Is that something that we're doing here in the state? And can you talk a little bit more about what that is for people who don't know? And on another token from our same employee, are you still asking for iPads so that folks can do more virtual communications with their family members? Is that something you're still collecting? If people want to donate, how do they do that? That's it.
So I think we're all using proning. It's been proven to be very helpful to patients when they have the COVID pneumonia. And basically this is something that's written into the order sets so that everyone is using this. If somebody is on a ventilator, then they are turned physically with the staff. If somebody is not on a ventilator and they're able to move, then we still ask them to lay on their stomach or on their side. And this just redistributes the oxygen and the various fluids within the lung and tries to get a better way of being able to oxygenate the patient by just the movement and gravity. So I guess that's the best way to explain it. It's really related to the changes in gravity on blood flow and the changes in the way that the oxygenation occurs within the lung. And so that ultimately results in some improvement in the patient.
So what we found from the early experience with COVID was that putting patients on ventilators early was actually not helpful. And so having learned those lessons, proning or putting someone on their stomach has the advantages that Dr. Sandoval just described, and we are doing that fairly routinely here. We are asking for iPads. It is hard to describe what a lifeline that can be. Not just for COVID patients, but for patients who are undergoing surgery and can't have their families with them. So yes, we are requesting iPads, and they are, a poor second to having a family member present with you, but it does give our patients a lot of comfort to be able to FaceTime their families.
Thanks, Brittany. Does anybody else have a question before we close today's press conference? Okay, well, thanks again, everybody, for joining us this morning. Once again, this was recorded, so if you do need a copy of this recording, let me know. We'll